Hello, everyone, and welcome to this RPTH Research Recap, where we dive a little deeper into the science being published at RPTH. My name is Marie-Laure Kipanidze. I'm a professor at the Faculty of Pharmacy of the Université de Montréal and a researcher at the Montreal Heart Institute in Canada. I hold a Canada Research Chair in platelets as biomarkers and vectors, and my research focuses on basic translational and clinical aspects of platelet biology. I am pleased to introduce Dr. Anna Stevens, an Australian-based hematologist and pathologist. Dr. Stevens' research focuses on blood disorders, platelet activation, and vascular biology. Dr. Stevens recently published a paper in RPTH. It's titled Beyond Platelet Activation, Dysregulated Lipid Metabolism in Defining Risk and Pathophysiology of Vaccine-Induced Immune Thrombocytopenia, and Thrombosis, or VITT. For those joining us live, please leave your comments and questions in the chat, which we'll be happy to answer during the discussion. And Dr. Stevens will look forward to hearing your presentation.
Thank you very much. So thank you very much for the introduction, Marie. I'm going to be talking a bit about my research, but before I get into that, I thought I'd just tell you a little bit about my background and my research and work. When I started as a doctor in hematology, as well as starting my PhD, this was in Melbourne, in Victoria, Australia, and I was at the Baker Institute as well as the Alfred Hospital. And my research at the beginning of my PhD focused primarily on predictive markers for venous thrombosis. And as with many people, the COVID pandemic threw my PhD into disarray, and I changed focus to really focus on COVID and then also vaccine mechanisms that may be associated with thrombosis. And over the last few years, I've spent some time doing a research fellowship at the University of Cambridge in the United Kingdom. And more recently, I have moved back to my hometown in this tiny little island at the bottom of Australia, where I live in Hobart, Tasmania. And I continue to work as a clinician and a researcher. And this is the lovely view of Mount Wellington out my window. But what is VITT? So vaccine-induced immune thrombocytopenia and thrombosis, also known as thrombosis with thrombocytopenia syndrome, or TTS, is a clinical syndrome that really gained notoriety after there was mass vaccination with adenoviral vector COVID-19 vaccinations. And during this time, there was recognition of a syndrome where people were developing unusual venous thrombotic events, as well as having low platelets. And over time, this has been established to be VITT, which is an anti-PF4 antibody syndrome. And the way that this presents is shown in the graphs in the middle. So the mean age was between 40 and 60 years. The overwhelming majority of patients had markedly low platelets and a high D dimer. And over on the right-hand side of the screen, there's just a graph showing the range of thrombotic events that occurred. But in particular, VITT presents with unusual cerebral venous sinus thromboses or splanchnic vein thromboses. And over the last few years, VITT has been established to be primarily due to a pathogenic antibody against platelet factor 4, also called VITT antibodies. And these antibodies are able to bind and strongly activate platelets, but also activate leukocytes such as monocytes and neutrophils, and result in these venous thrombotic events, as well as decreased platelets. But the question still remains as to why do these antibodies occur in the first place, and then what other mechanisms may be increasing our clotting risk. And some of my research during my PhD has focused on lipid species and how they modulate both bleeding and thrombosis. And so I became interested in how lipids may modulate thrombotic risk in VITT. So to try and answer this question, we developed a multi-centre trial here in Australia. Small numbers because VITT is a rare condition, but we had 17 patients who were nationally adjudicated to have VITT, and they were compared to controls. Now, these controls were patients from a longitudinal profile study called the COVIS study, who were day 6 post-adenoviral vector COVID-19 vaccination. And we also had another cohort which was unprovoked venous thromboembolism to see how VITT differed from standard VTE. With these 3 groups, we then stored plasma and also collected some data, including demographics, platelet count, and D-dimer, and then went on to perform lipidomic analysis with linear regression to try and look at the difference in lipid species in VITT compared with the vaccinated controls, and then VITT with standard venous thrombosis. And so this is a basic overview of our lipidomics workflow, but just to say that all of these samples were sent to the central laboratory where they were prepared and underwent lipid extraction. At the Baker, we can analyse approximately 820 lipid species and 42 lipid classes. And then we went on to perform our bioinformatic analysis to look at the difference in lipidomic composition between these 3 cohorts. So on the left-hand side of this screen is our cohort characteristics for the patients that developed VITT. I'm just showing you the ages, the time post-vaccination, which was always the first dose of Chaddock's vaccination, and then the types of thrombotic events. And on the right-hand side of the screen is a table demonstrating the percentage of female gender across the cohorts, and then also median age. And I will note that the median age was quite different between the cohorts. So first of all, we found that there were significant lipid differences in VITT compared with vaccinated controls. We found that there were 162 lipid species that were associated with VITT and 16 classes. This is a busy forest plot over on the left-hand side of the slide, but this is showing the lipid classes on the left-hand side. The non-statistically significant lipids, or p-values more than 0.05, are grayed out circles. The statistically significant lipid species are circles with the black around the outside. The lipid classes are the purple diamonds. And then the 10 most significant lipid species that were either up or down regulated in VITT are these circles in orange. And then we also looked at VITT compared to standard venous thrombosis. And we found, yes, there were some differences, but overall, the lipid signature was a lot more similar between VITT and VTE. What we did note was that there were 12 lipid species that were different and 3 lipid classes. And on this forest plot, it is the blue circles that highlight the most significant species that are different. And in particular, we noted 5 acylcarnitine species that were downregulated, and I'll talk a bit about that more on the next slide and why that's important. So that's all very good. I've described to you a number of lipid species that are changed, but why is this important? Well, firstly, we can say that the lipidome in VITT looks very different to the controls post-vaccination. The first thing that we noted was that there were higher levels of phosphatidylserine, which is known to be a prothrombotic phospholipid promoting platelet activation. So this negatively charged phospholipid is on a platelet surface and promotes the coagulation cascade and is consistent with really the central role of platelets in VITT, and also the known role of PS in heparin-induced thrombocytopenia, which is a condition very similar to VITT. We also saw high levels of some ceramide species, which are known to be prothrombotic or inflammatory. ceramides are a subclass of sphingolipids, which have been associated with a range of cardiovascular disorders, and this is independent of conventional risk factors such as weight or cholesterol levels. And there are studies going on to see whether reduction in ceramide species also reduces cardiovascular events. It's thought that ceramides may affect cardiovascular disease or be prothrombotic in a number of ways, but in particular, they may increase inflammatory markers and also promote endothelial cell dysfunction. The third interesting finding was that there were lower levels of plasmalogen lipid species, which leads to increased oxidative stress. So normally plasmalogens act as natural anticoagulants, so they reduce oxidative stress for our cells. And so lower levels is associated with increased oxidative stress. And these findings have also been implicated in cardiovascular disease and other very inflammatory conditions such as COVID-19. And then to come back to the acylcarnitines that I mentioned before, in both the VITT samples compared with the controls and then also VITT compared with VTE, we saw lower levels of acylcarnitines. And this is interesting because normally these lipids act as anticoagulants through their effect on factor 10A, and lower levels have been previously shown to be associated with venous thrombosis. What's more is that we were part of a collaborative study a few years ago, which is the COVIS study, and this is where we also used these control samples. But this study looked to longitudinally profile participants pre and post different COVID-19 vaccinations. So this included both adenoviral vector vaccinations and mRNA vaccinations. And in this study, we showed that there were 9 lipid species that were altered post adenoviral vector ChAdOx1S vaccine that were not altered post mRNA vaccination. And these included reduced plasmalogen species, which we know lead to increased oxidative stress, and then also reduced acylcarnitine lipid species with this increased risk of clotting. So our more recent findings with VITT are consistent with these previous findings in the COVIS study and start to provide a hypothesis of how or why lipids are involved in the development of VITT. Regarding our study, there are some strengths and limitations. This was a prospective study. We had adjudicated or nationally adjudicated cases of VITT with these 2 comparator arms, but it is a study with a small number due to the rarity of the disease. And unfortunately, we weren't able to age and sex match. And so we had to do this as part of our analysis. We also, at the start of this study, only collected plasma when it would have been very, very interesting to look at platelets. But you learn from your mistakes or the things that you would change about studies, so we didn't collect platelets. In terms of clinical implications of this, so when we think about anti-PF4 disorders, this includes heparin-induced thrombocytopenia, which is described around 50 years ago, through to VITT, described in 2021. And since VITT, there has been descriptions of other anti-PF4 disorders, including post other vaccinations, such as the HPV vaccination, as well as following some infections, and also in patients that have paraproteins. So it appears we're learning more about these disorders, and our findings can potentially help to risk stratify who would develop VITT when we understand more about this disease. We could also look at lipids as potential biomarkers for prediction or prevention, and to try and understand more about the molecular insights of VITT, we're also currently looking at the proteomics of VITT. So to conclude, we showed that VITT has a distinct lipid signature, which is not seen in vaccinated controls who do not develop VITT. We have described some important prothrombotic changes, including increased phosphatidylserine and ceramides, reduced plasmalogens, and also reduced acylcarnitine species, all of which have either these increased thrombotics or pro-inflammatory effects. We have shown that VITT is relatively similar to standard VTE, but has some reduction in acylcarnitine species, which may provide a mechanism for different types of thrombosis. And hopefully we are describing a metabolic signature for risk stratification as we understand more about these disorders. So thank you very much, and thanks to everyone in my laboratory, particular my supervisors, Karl-Heinz and James.
Wonderful. Thank you, Hannah, for that very interesting presentation. Just a reminder for those of you joining us live, so there's a comment section where you can put your questions and comments to us, and we'll keep an eye on them as we have this discussion. Hannah, this must have been an extraordinarily difficult study to organize, with so many sites sending you those very rare and specific samples. Could you comment perhaps on how you ensured that the blood collections was standardized and that the plasma that was collected was of good quality and sent to you when it was sent?
Yes, it's always difficult, isn't it, when there's many sites involved. We had a small study team, which was, I was one of the primary investigators, and we had sent out procedures to all of our hospitals that were involved. In the end, it ended up being a lot more local sites, just in terms of making sure that we did have samples collected within a 4-hour time period and that they were able to be processed adequately. But we did collect them over 2 sites, so Victoria and New South Wales, and then we also had South Australia. But it is always challenging when there is multiple sites involved, and I think that you take people's word on procedures being followed, of course. But yes, and then with the COVIS study, this was another study where they were specifically looking at this longitudinal profiling and had we were involved in this from early on, and so understanding of their procedures.
That's great. I also noticed in the paper that you were using citrated blood samples, whereas we often use EDTA, anticoagulated samples, to process plasma. Is there an importance of these pre-analytical variables when you look at lipidomics specifically?
Yes, I think with any of the multi-omics, all of these pre-analytical variables play such a large role, don't they? Clinical factors, so fasting time or medications that patients are on, but then also thinking about how the samples are stored or processed. Regarding EDTA or citrate, we actually did collect both, but had decided with our lipidomics laboratory to process the citrate sample. And I think that was just based on the number of freeze thaws that had happened with some of the other EDTA collected samples. And we wanted to have that as standardized as possible.
Yes.
And I think as long as we decided to use citrate for all of the 3 cohorts, then that will ensure that we get as accurate and precise results as possible.
I would imagine it must have been a lot of discussion with the laboratory team to make sure that everyone is on the same page. You mentioned also that some of the patient characteristics were different, and you highlighted sex and age particularly. Why are these important?
Yeah, so we know that there are significant lipid changes as people age and also between sexes. And as I mentioned, there are definite other factors such as fasting time or recent types of food that has been ingested that play a role, as well as other medications. One of the challenges that we faced with having these multiple studies, and also with such a rapid turnaround time in terms of trying to get ethics and multiple people on board, is that we had very limited demographic data. And so that was essentially limited to age and sex. This was adjusted for in our analysis, in our linear regression model, but it would have been amazing to have age and sex matched controls, but unfortunately that wasn't possible.
And also that I would understand that would have been very difficult to do, especially with the VTE cohort. That was a historical cohort. That was a comparison for your VITT cases. Was that decided beforehand specifically that you wanted to use these VTE cases before COVID and before vaccination to have no bias? or is it just a convenient sample that was just stored in your biobank and was available at you at the time?
It was actually my PhD project that got halted for some time in the setting of COVID and no longer being able to go into hospitals. And so then we were able to continue this and then also take it in the direction of trying to understand how these VTE samples looked different to VITT profiles. One of the benefits we did have is we knew that they were all pre-COVID samples and none of our patients had been infected with COVID, and that wouldn't affect the results at all. So part of it was convenience, and part of it was that we were continuing this study that we were already doing.
It worked out really well, didn't it?
It did. It did.
Do you have any idea of where those blood plasma lipids are coming from? You mentioned platelets and that you regretted not having access to platelets, but is there other sources? Are there other sources that we should be considering when we're thinking about these plasma lipids?
Yes. So I don't think our study doesn't give us good information about where the lipids come from. Yes, it would have been amazing to have platelets, but alas. But so I think part of the thought, if we did, as I mentioned, we're looking at the proteome, but we are also considering looking at extracellular vesicles in the plasma and whether or not we could look at cell of origin this way, although again, this would be harder to link up with lipids. But I think with the data we've got, we're unable to say exactly what cell of origin they're from.
And how do you view them, those lipids, at this time? Are they more of a marker of a disease state, or do you hope to see them as predictors or maybe even targets ultimately for VITT or prevention, at least, or prediction? I don't know. How do you see these?
I think at the moment I see them as biomarkers, but I would hope that we could use them for prediction. Part of it is that it's such a rare disease, and so thinking about who you screen and when and how you use it becomes very challenging. In terms of therapeutic targets, I think lipids are always an interesting but difficult discussion when you think about lipids such as phosphatidylserine. If people don't have enough of that with their platelets, we think of disorders such as Scott syndrome, where you can't have expose your phosphatidylserine on the outside of your platelet and you increase your bleeding risk. So we think that lowering lipids like that would actually have the opposite effect. But one interesting part to look at may be ceramide reduction in these disorders. So ceramides, as I mentioned, are being looked at in cardiovascular diseases. And because ceramides often travel within cholesterol molecules, and particularly within LDL, if you lower LDL, such as using statins or the newer inhibitors, you can also lower your ceramide levels. So using some of these existing therapies may be options to think about how we can reduce this disease. But I think we have a long way to go about learning about the pathogenesis and also how we predict it before we get to that point.
Oh, yes, definitely. I think we've managed to go through most of the questions that we've received and that we have, or at least I had as I was listening to your presentation. So I'd like to maybe leave you with one last question that is a bit open-ended. If you were to redo this with your experience today, is there anything else that you would have liked to do differently, or maybe include that you haven't managed to do in the previous study, and perhaps that could be a possibility for the future?
Definitely. I think that's always the way, isn't it? When you run a study, you think about all the things you could have done differently. As I mentioned to you, I think one of the things that really stands out to me, and potentially as a young researcher, is organising for more sample than what you think you will need, because that was one of the challenging parts the whole way, is that we couldn't do extra markers because there wasn't enough sample, or it had gone to other laboratories. So having as much as possible, and then looking at those other cells, platelets or leukocytes where we could, but also collecting like that granular clinical detail and thinking more about the wide amount of like demographic data or past medical history that would be useful in these scenarios.
Hannah, it's really been a pleasure to chat with you on this important study. Thank you so much for presenting your work and giving us an insider look into your recent publication. We hope our viewers have enjoyed this presentation, and will read the full detail of your paper on our site, rpthjournal.org. Thank you for those of us who joined us live, and don't forget to follow us on LinkedIn, Facebook, Blue Sky, Twitter, X, and YouTube. Thank you for watching, and keep an eye out for the next RPTH recap.